we're going to get a little bit into more detail in regards to joint complex dysfunction. So I'm going to skip that first slide because we're saying the same exact thing. We're going to get into this concept of the things that are common to all subluxation concepts. I'm sure some of you, and some of you may already be here. You might live and die by the term subluxation, or you might use something more like a joint restriction type model. But common to all concepts of subluxation, we have some sort of identifier of kinesiologic dysfunction as well as some sort of neurophysiologic dysfunction. From a I just said it. From a kinesiology dysfunction, we'll just stick there before I flub up even more. We're talking about levels of hypo or hypermobility, change in motion, which we mean is what we're talking about when we say aberrant. So some sort of alteration in motion, and levels of compensatory hyper include hypomobility as well. That can also be from a compensatory standpoint. We know due to the innervation within those joint complexes, we can have levels of disafferentation, altered sensory input. We can have compression of our nerves, especially when it comes to increased restrictions leading to osteophytic changes, narrowing spaces, etc. And we can also have altered axoplasmatic flow, or the ability of our nerve processes down the axon to transmit information into our synaptic cleft to stimulate different types of chemical responses. All these models have some sort of significant influence or impact on, or include an impact on the nervous system from some standpoint. When we think of that subluxation lesion that we mentioned is that particular lesion that chiropractors treat, from a mechanical treatment standpoint, we're looking at something either being static or dynamic. We can have local changes from an inflammatory or biochemical standpoint. And the changes can occur from just functional changes into increased pathological changes as well. But when we say something like joint complex dysfunction, how does that relate to that subluxation model? The easiest way to define this, or the best way I should say, is we're saying a joint complex dysfunction is a type of subluxation. We're involving and looking at specific joint structures, their muscles and ligaments, blood supply, nerve supply, all surrounding that area. When we think of a joint complex dysfunction, that's the type of subluxation that chiropractors treat. We are not talking about complete dislocation, right? So that's how we're going to define that joint complex dysfunction within that subluxation umbrella. Because, and we mentioned like universal language. When I say something like when I use the word subluxation with a orthopedic surgeon who might not be well versed in chiropractic theory or healthcare, he might think I'm talking about complete dislocation. He or she might be thinking I'm talking about complete dislocation. So it's important to incorporate this joint complex dysfunction as what we are particularly treating, so we can somewhat meet on the same level when it comes to language and communication in those terms. This particular joint complex or dysfunction within that joint complex, we're talking about alterations in function of the structures that make up that particular motion segment. Joint structures, ligaments, muscles, fascia, blood, and nerve supply, because we know that all of those elements are involved from just a basic anatomical standpoint. Dysfunction and changes pathologically within that anatomy often interact to produce different types of symptoms. When we are referring to joint dysfunction, we're referring to a loss of joint plane movement that cannot be produced by voluntary movement. So some level of hypomobility or decreased motion. What that means is when you palpate and you go to end range, we get a loss of joint play at that end range, right? It's giving us a restriction. The secondary approach to that is because we have that loss of joint play, it cannot be produced by voluntary movement. So if I have a right rotation restriction of T4 on T5, that also means when I go through voluntary movement, I can't make it occur, right? So loss of joint play that cannot be produced by voluntary movement. It can be painful when joint play is lost, doesn't always have to be present. And we can have a wide variety of reflex effects or compensatory effects that occur. Different muscles can become hypertonic and others can become inhibited or weak. And that imbalance of functionality leads to chain reactions of dysfunction. So if we're overutilizing one thing and underutilizing the other, we have compensatory mechanisms at play. And that faulty movement patterns can occur throughout that locomotor system or that musculoskeletal system. It can happen from, this says mechanical overload, but not always, right? If I'm not using something, I can end up with a manipulable lesion or a joint dysfunction as well. But this particular chart is just showing that cascade that can lead to different types of symptomology. We have different types of neurophysiologic reactions, neurogenic inflammation, different types of peptides release leading to sensitization processes, all things we know just from a cascade type of approach. Now, when we get into causes of joint dysfunction, remember that these can be the cause or end up causing, but let's stick with causes of joint dysfunction. We can have elements of trauma, immobilization, maybe a resolution from some sort of serious pathological condition or injury that was occurring, usually some sort of inflammatory condition, disc degeneration overall, different types of congenital abnormalities, delays in development, so developmental factors, erosive arthritis, different types of autoimmune arthritis, instability when it comes to ligamentous structures, and overall postural syndromes or quote unquote issues. Postural syndromes. Some element of trauma is the most common cause of joint dysfunction. And when we're thinking of trauma, we're also thinking of micro trauma, not necessarily just macro trauma. So when we think of micro trauma, this is like improper stabilization, response to repetitive perturbation or asymmetrical loading imbalances. So those micro trauma just from daily movements overall that might be less than ideal. Maybe you're always picking up your books off the floor by hunching over and rounding your back every single day. That's repetitive micro trauma over time. So most common cause of joint dysfunction, trauma, typically micro trauma, but we can have elements of macro trauma as well, right? Sustained injuries, major impact injuries, sprains, strains, those can also play a part as well, but it's more common from that micro trauma approach. Surgery, you can consider that a macro trauma, but it's almost, I would categorize that into immobilization. There's kind of like an overlap there if you think of surgery. For example, if I think of, let's just say someone gets their ACL repaired and they have to wear an immobilizer for a couple weeks before they start moving that knee. They might get postural adaptation or immobilization adaptation that causes joint dysfunction just from like sitting more often, utilizing crutches, not necessarily that joint dysfunction is not necessarily occurring within that joint of the knee, but other compensatory mechanisms overall. So it's kind of like that crossover of macro trauma and immobilization. Because, for example, when we're talking about immobilization, we know, and I believe this was a quiz question, if not a midterm question, complete immobilization is not essential for connective tissues and joint degeneration to occur. So when we think of immobilization, we're also just thinking of joint restriction. A type of immobilization we can think about is stress deprivation, which leads towards degeneration of tissues. We're thinking about things like underutilization or disuse. So for example, if we stick on that surgery standpoint, I had to have a surgery on my knee. If I'm resting and sitting down for more prolonged periods of time than I'm used to, there can be adaptations within my pelvis, within my lumbar spine, within my hip capsule because of underutilization or disuse that is not typical of my normal day-to-day processes. That leads into prolonged inactivity or bed rest. If you're sick for extended periods of time, how bad is it when you have the flu and you've been what seems like bedridden for like 2.5 days, and then you get out of bed to like use the bathroom or get some water and tea, and you're just like so stiff and you can barely move? Obviously, there's systemic inflammation going on due to your illness, but when you're laying down for prolonged periods of time, that is a level of immobilization leading to joint dysfunction. Also included here is this use of cervical collars or lumbosacral supports. That is a level of immobilization. Cervical collars, the research has come out over the past like 20 years or so, where cervical collars are obviously and should only be used when it comes to concerns about stability of the cervical spine post-traumatic injury. Even things like such as lumbosacral supports, like that was a big hot topic, right? Of like, oh, everyone needs like I hate the word like ergonomic chair because it's like, well, you should just be standing anyway. But lumbosacral supports that were like little attachments to desk chairs for office workers and stuff to like provide that normal lordotic curve while you sit. But what is happening there is like you're actually taking away your postural muscles from actually doing their job. So it's actually doing more harm than good in the long run. I literally just changed my posture right there because my low back was rounded and now I'm sitting up straight. So it's better to teach yourself and to actively sit up straight rather than utilizing something like that. Some of you might disagree with me too when it comes to like those postural shirts or different types of sports bras that say like, oh, it helps like bring the shoulders back and help your thoracic posture overall. Well, you should be activating those things, not relying on some sort of brace mechanism to do it. Because over time, that immobilization can cause different levels and progression of degeneration. Just a little review from that Kirkcaldy-Willis model of spinal degeneration we talked about, I believe, in week 3. Where you may not even have any symptomology within these initial phases, because pain might not necessarily be present at that time. But different levels of immobilization can lead towards degeneration as well. Advancing off those traumas and immobilizations is the theory of causation from meniscoid entrapment, displaced disc fragmentation, compensatory muscle spasms, or periarticular connective tissue adhesions. So let's go into those a little bit. When we think about meniscoid entrapment, we're talking about that that little baby meniscoid, is so cute, within your zygapophyseal joint complex. So within your facets. So you have your facet capsule, and then there's a tiny little cushion of a meniscoid to kind of help move through motion, right? So if we have some sort of meniscoid entrapment within there, we're creating a level of mechanical restriction. This can increase pain, produce reflex muscle spasm because stimulation of those nociceptors within that joint capsule, which can progress and further progress restrictions in movement and cause additional pain. From an intervertebral disc standpoint, we can have primary discogenic pain incorporated with some sort of displaced disc fragment. This is typically like an internal disc disruption or derangement is the word that we like to use. Now, when you think of displaced disc fragment, we're not talking about protrusion leading down into the spinal column, et cetera, right? We're talking about some sort of maybe annular tears. I didn't want to use the term derangement, but that's the first thing that came to mind. Some sort of disc fragment that might be causing a slight herniation, but it might not be causing a herniation as well. That displacement of that tissue, it's not perfectly smooth and causing that cushion for our vertebral column. It can produce mechanical restriction as well as muscle spasm, which leads towards that stimulation of nociceptors within the outer portion of that disc. So that can also be a cause of some sort of joint dysfunction. Reflex spasming. Since our joints and our discs are innervated by different types of nociceptors, we can have a reflex spasm of musculature that cross different injured areas, such as your multifidi, the rotators, your paravertebral muscles. And those restrictions in those muscles due to spasm can cause joint restriction overall. Prolonged positions in a certain plane or a certain motion just due to those reflex muscle spasms. It's like, which came first, the chicken or the egg? We can also have periarticular adhesions, which can limit joint movement as well. When we think of periarticular adhesions, we're thinking of adhesions within the soft tissue surrounding that joint complex. And some of those include degeneration of the articular cartilage surrounding that joint, alterations in hyaluronic acid water content, our ability to absorb into the fluids of the surrounding tissues, contractures within the joint capsule, ligamentous adhesions. So if you've had any injuries to those surrounding areas, sprains, strains, and even fibrosis from a resolution of inflammation. So fibrotic scar tissue buildup over time without being manipulated or flushed out, broken down, can lead to joint dysfunction as well. So it might not always be just due to that particular joint complex. Things surrounding it can be limiting that joint motion as well. Periarticular adhesions, expanding even more off that. This can be of different magnitude on one side of joint capsule compared to the other, depending on mobilization or depending on immobilization. For example, my right-sided zygapophyseal joint capsule might be undergoing some more wear and tear than the left side, depending on injury processes, immobilization, limitations, and compensatory patterns overall. These types of adhesions, these surrounding tissue structures, are likely cause of joint dysfunction, particularly in different types of chronic situations. The example here is fascial contracture, but we can also think of muscular spasms leading to overuse or disuse, so you end up developing different types of adhesions within those tissues. But if you're dealing with some level of chronic joint dysfunction, those other tissues or adhesions will probably be involved. Because all of our synovial joints have different ligaments and capsules that are susceptible to shortening, are susceptible to scar tissue buildup depending on the injury, that can cause restrictions within your joint. Muscle dysfunction can also cause restrictions. When we're thinking about structural dysfunction, we're going to categorize that more as like structural lesions to the central nervous system, leading to elements of spasticity and rigidity. So when we're talking about our structural lesions to these muscles, these are more lesions towards our pyramidal tracts in our descending pathways, because these are going to include spastic muscle changes from a central nervous system standpoint, which obviously, if we have increased in just neurological spasticity of those muscles, you're going to have joint restriction as well. Am I going to be able to manipulate those? No, that's from a central nervous system issue. I'm talking about things like stroke, traumatic brain injuries, things of that nature, degenerative disorders. These can also happen or occur as rigidity, lesions in the extrapyramidal system or extrapyramidal tracts. So you have hypertonicity and increased tone. This is, again, a neurological issue, not necessarily manipulable, right? Parkinson's disease, different types of Parkinsonian syndromes, focal dystonias, spasmodic dysphonia, torticollis. Those are usually coming from a more rigid type of standpoint. But muscle dysfunction overall, whether it be the involved muscle or the involved muscle or a compensatory muscle, can be the originator of some sort of joint dysfunction or disturbance as well. We can have levels of hypertonicity, so muscle that has over time increased in tone. We talked about this in CP3. So that muscle is going to be resistance to movement or reactivity or both. Levels of hypotonicity or inhibition, so that muscle is a little bit weak or inhibited. It's not ready to be activated. It's not being used appropriately. And which came first, the chicken or the egg? Is that hypertonicity causing joint dysfunction, or that joint dysfunction can be causing increase or decrease in tone? When it comes to disruption of our interneuron, because we know we have an interneuron that helps our daily movement processes, right? I always think about like PIR and RI when we talk about this, because I have to have that interneuron activate when I move my bicep to shut off my tricep to go through proper movement patterns. But if we have some level of dysfunction, joint dysfunction, altering our mechanoreceptors and nociceptors, we can have altered movement patterns because of it. Our postural muscles can become hypertonic, but they can also become weak. Remember, hypertonicity is not linked to strength. Hypertonic tissue can also be weak. And our phasic muscles can become inhibited over time just from a compensatory mechanism. This reciprocal inhibition is not what we're talking about in regards to treatment wise. we're talking about reciprocal inhibition in regards to compensatory patterns. So compensation mechanisms, not treatment modality. Our postural muscles, like we said, they may or may not be weak. We can have increased reactivity to stimuli, so they're overutilized. And it'll cause inhibition of the antagonist because we're overutilizing that agonist in whichever way that we are. Our phasic muscles, they might have an inability to respond to stimuli in approach time, so they have that increased threshold, and that inhibited muscle may or may not be weak. Weakness does not correlate to those hypertonic or hypotonic muscles. We can have a hypotonic muscle that is perfectly fine in regards to strength. It's not common, but it can occur. We went over these two in CP3, muscles that are prone to, I don't like this term, tightness, but muscles that are prone to, I would say, sensations of tightness, and muscles that are prone to weakness. I'm going to skip through this. We've done lower cross syndrome. We've done upper cross syndrome. We should know what those are by now. Whether we're having elements of hypertonicity or inhibited or hypotonic muscles, it can cause alteration of the load distribution over joints. So that's what we mean when we say it might not be that hypertonic or hypotonic musculature might not only be a result of joint dysfunction, but it may also be producing joint dysfunction. So it's kind of difficult when people say, oh, well, what do you do first? Do you adjust or do you do soft tissue work first? You can attempt to do both depending on the patient in front of you. It's very hard to determine, and if I had some sort of psychic ability to understand it, some people are of the concept of, oh, let me try to mobilize this joint and it might help relax the hypertonic muscles surrounding it. But if that doesn't work, you might want to address the hypertonic tissue and then adjust. Because sometimes what happens is if you address the soft tissue and then you repalpate that particular joint complex, you might realize that that actually was impacting that joint dysfunction, or vice versa. Resultant alteration of movement patterns in which these muscles are involved, so your different hypertonic and hypotonic muscles, can produce distortion of the sensory picture or how you interpret that sensory information. When things aren't being utilized properly, we're going to have a disruption of those sensory mechanisms. This can also contribute to the development of myofascial trigger points. If I'm sitting in a prolonged posture over time, I'm not utilizing, I'm trying to think of the best way to describe that. If I'm sitting in a particular posture over time and I end up getting sustained muscle contraction, my sensory input is going to be altered. So when I get that level of myofascial trigger points, that's why we can have numbness in the area, things of that nature, because we're shutting off that mechanism. It's not functioning properly. It's not going through contraction and relaxation. It's constantly contracted. So we're not going to get adequate sensory information. When we have reflex muscle spasms, it can be due to a response to some sort of nociceptive input. I always describe to patients as, well, I always describe muscle spasms as a protective mechanism, and it's typically what it's thought to be. If you've ever, so the common occurrence is when someone, quote unquote, throws their back out. and they come into your office and they're hunched over and they can barely move because their lower erectors, let's just say for this example, are in like this hyperspasmodic state, that's typically a protective mechanism for whatever occurred at that microscopic level, whether it be in the intervertebral joint complex, the intervertebral disc, that zygapophyseal joint capsule, even the tiny ligaments within our intervertebral joint complex. The larger muscles around it might be going into spasm to protect that area overall. That reflex spasming is only type of muscle dysfunction in which there's continuous electrical activity throughout the entire muscle. So that whole muscle is contracting, as opposed to something like a trigger point. You end up getting this barrage or increased nociceptive impulse. And so it's of such sufficient intensity that it causes all the alpha motor neurons to, I was going to say spasm, but to fire, to spasm and protect that more isolated microscopic structure. This leads to contraction of those extrinsic muscle fibers. So it's typically a result of that intense nociception arising from that tissue, especially common with IVD degeneration. So maybe you've heard a chiropractor, I've said this before too, where sometimes that reflex spasm from that microscopic injury can itself become the source of pain. That reflex spasm or that reflex muscle spasm is a self-limiting condition. It usually resolves spontaneously as the intensity decreases from those nociceptive impulses. However, even when those nociceptive impulses decrease, there could still be hypertonicity as a result of that muscle spasm, especially if it's been going on for a long time. So there might be some resultant or post-spasm hypertonicity or inhibition still within that muscle, even when the spasm decreases. This can lead to chronic pain and greater fatigue if those muscles are left untreated or ineffectively treated. So although that muscle spasm might go away, it's important to still address those tissue changes that could have occurred. Now, I don't really like the term muscle tightness, but when we talk about muscle tightness, we're typically relating it to when that connective tissue of the muscle, like fascia and tendons, are continuously in a shortened state. I like to think of tightness as a sensation, not necessarily a condition, but we can coincide this with fascia and tendon being in a continuously shortened state. That muscle has increased reactivity to both central and peripheral stimuli because it's adaptively shortened. And usually muscle that is shortened will, so we're going to say that, usually muscle that is shortened from that tendinous standpoint will tend to dominate movement patterns in which it's involved. It's easier to contract. It's usually tight because of overuse. So it has a tendency to be involved first, per se. They have a great resistance to stretch, just like hypertonic tissue. And it usually tends to inhibit its antagonist. It likes to do the work, it likes to become more involved. Since it inhibits those antagonists, those muscles that are now inhibited or left out of that functional movement pattern, they usually don't activate or they become weakened because they're not being involved in that typical movement pattern that they should be. And when we think of muscle tightness and shortening, we're thinking of these shortened muscles even in their resting state. So even without activation, they are presenting as tight. The thing that I'm thinking about right now, adaptively shortened, is our pec minors, for example. It's usually resistant to lengthening. more so than hypertonic tissue, because remember, hypertonic tissue doesn't have to be within that whole muscle. But there is a huge overlap between muscles that are prone to quote unquote tightness and those that tend to become hypertonic. So they don't have to be, but it is common that they are involved. When it comes to joint dysfunction, we can also have skin and subcutaneous soft tissue dysfunction as well. These different types of reflex changes can take place in the skin and subcutaneous tissue. So they might end up experiencing pain and other reflex changes in the surrounding tissue around that joint complex. And you might also be experiencing skin zones that are hyperalgesic or have increased sensitivity to pain. That particular area of skin surrounding that particular joint dysfunction can have increased sensitivity. So different types of innocuous stimuli that usually is not painful becomes painful. And this is that peripheral sensitization type of process. This final slide is just a very word-heavy depiction of this joint complex dysfunction. Here, up top, is all the different types of therapies that we can utilize to impact that nociceptive input resulting from that joint complex dysfunction. Don't need to memorize this in any way, but remember that these different types of cell mediators within that inflammatory process can promote and sustain these types of restrictions or dysfunctions. And if we don't impact them in some way, we just lead towards this cyclical process of impacting from that neurophysiological standpoint. All right, I'm going to stop sharing.